Welcome everybody. It's lovely to see our hall so full after COVID, where often it was completely empty for more than a year. So it's absolutely great that you're here for the Stevens Lecture. This is actually the 53rd Stevens Lecture. These started in 1950 when Edwin Stevens, who was the inventor of the first wearable hearing aid, donated enough money to keep these lectures going. I'm not sure if it's in perpetuity, but for a good long time anyway. And this is the 53rd. And we have the Stevens family here. We have Lord David Stevens, we have Howard Stevens, we have Desiree Christie, and our speaker that I'm going to come on to. So our speaker tonight, we're really privileged and lucky to have Matthew Taylor, CBE, who's a British former political strategist and current chief executive of the NHS Confederation. He was previously the CEO of Royal Society of Encouragement of Arts, Manufacturers and Commerce, or the RSA, between 2006 and 2021. In 2005, he was appointed by Tony Blair as head of the Number 10 Policy Unit. In October 2016, he was appointed chair of the Review of Modern Employment, established by the Prime Minister Theresa May, and the Taylor Report, Good Work, was published in 2017. He's a writer, a public speaker, a broadcaster who's been a panelist on Radio 4's Moral Maze, and he appears quite frequently on the Today programme. In fact, you might have heard him this morning on the Today programme, where he gave quite a good plug for this evening's meeting. So with no further ado, Matthew, if you come up. Matthew's going to talk for about 40 minutes about this subject, the NHS's 75th birthday, and the need for a real health policy. And then, as before, we'll have a question and answer session for about 20 minutes. So if you think up some questions, then we'll do a sort of BBC question time event after that. So over to you, Matthew, and thank you so much.
Thank you. Well, thank you for inviting me to give this lecture. I'm surprised to see so many people here. Apparently this qualifies for CPD points, so that's clearly explains why a lot of you are here. Edwin Stevens, as we've just heard, kindly founded this series in 1970, and I was fascinated by that fact that he, in manufacture, invented the world's first wearable electric hearing aid. When you think about that, must have made such a huge difference to so many people's lives. So I look back over the dauntingly impressive list of previous speakers in this series. I notice how agenda setting it's been. Patrick Lawther on air pollution back in 1975, Crispin Tickell on climate change in 1991, Renan Gillan on reproductive cloning in 1998. But you've also been willing sometimes to court controversy, whether it was Ludovic Kennedy on assisted dying in 1993 or Princess Anne opining on what she described as medical mumbo-jumbo. So I look forward to answering questions later, but these associations with Edwin Stevens and past lectures put me in mind of another Q&A session when I was chief executive of the RSA. It was the annual President's Lecture chaired by the redoubtable Prince Philip, and that year given by Sir David Attenborough. So when the speech was over, two problems became apparent. So on the one hand, Prince Philip in the chair was not someone to suffer fools gladly. So if he didn't like the question from the floor, he'd either completely ignore it or substantially edit it before he then relayed it to Sir David. But also due either to the acoustics or perhaps to resistance to wearing a hearing aid, the Prince actually only caught a part of the question that was asked, and then Sir David, who had a similar challenge, only caught some part of the question after it had then been reinterpreted by Prince Philip. So the members of the audience who were selected by the Duke were in equal measure honoured to be addressing these two giant figures, but also completely nonplussed by the almost complete lack of correspondence between the content of their inquiry and Sir David's answer. So I can't help wondering whether there's a kind of parallel here with what can often happen when well-intentioned instructions from the top of the NHS finally reach the front line. So tonight I'm going to propose we use the occasion of the NHS's 75th birthday to develop a more ambitious national social contract for healthcare. This is more practical and more achievable than it might sound. In some places, some elements already exist. The potential is evident. But to achieve it for the nation will require us to make a more profound commitment and to rise to two sets of challenges. First, the need to reset relationships between the public and our own health, between the centre and the NHS, and between all organisations involved in health and care. And secondly, the urgent demand for investment, not just the amount that is invested, but also where we invest. So firstly, the challenge of resetting the relationship with each other. Who is responsible, in charge, accountable, empowered to improve our health? So for a start, I think we need to recognise that health policy is about a lot more than the NHS. And you all know this, of course, but from the beginning of the Industrial Revolution to the start of the 20th century, major advances in life expectancy were the result of improvements in nutrition, hygiene, housing, sanitation, and other public health measures. As we progressed through the 20th century, vaccination for infectious diseases in the 50s and 60s and reductions in smoking rates from the mid-1970s continued to make a positive impact on our life expectancy. Indeed, it's only in the most recent period of history that the treatment of disease has been amongst the main factors in driving our average life expectancy higher, particularly with improving heart disease and cancer outcomes. But over recent years, average life expectancy has levelled off, and since COVID, it's fallen. This levelling off has happened in other countries as well, but the trend appears more marked here. The pre-COVID levelling off was worse for people in the most deprived areas, where life expectancy actually decreased for women. Now, access to healthcare makes a difference to life expectancy, and countries with universal coverage do significantly better than those without. The inverse care law, the higher degree of strain on care we see in disadvantaged areas, contributes to unequal outcomes. But in the end, the actions of the NHS itself are much less significant in both determining life expectancy and healthy life expectancy and the differences between people and places than are other factors, particularly what are referred to as social determinants. It's now 13 years since the publication of the Marmot Review, Fair Society, Healthy Lives. Marmot and his distinguished team of commissioners recommended 6 areas for action to address health inequalities. These included early years education and support, good work and adequate living standards, as well as investment in prevention and community capacity. The Health Foundation follow-up report, Marmot 10 years on, published just before COVID hit and before the cost of living crisis, found that most of these factors had deteriorated over the decade, with, for example, rising child poverty, poorer quality of work, declining youth and other public services. And of course, COVID itself shone a very unforgiving light on our deep health inequalities. The shocking healthy life expectancy gap of 19 years between our most and least deprived areas in part reflects another gap. This is between the government's stated intentions on public health and the reality of inaction. Last year, the government published its Levelling Up white paper. It included the commendable target of increasing average healthy life expectancy by 5 years. The Health Foundation then explored what it would take to reach this target based on current policies and trajectories. And it reached a figure of 192 years. That's the year 2215, which would also risk clashing with the publication of the government's workforce plan. Any serious attempt to improve life expectancies and reduce health inequalities has to involve action across Whitehall, backed by commitment from Downing Street. As former Secretary of State Patricia Hewitt argued in her recent report, to get back on track to rising healthy life expectancies, we need a national mission, not just an NHS mission. But unfortunately, the government's been going in the reverse direction. The Health Disparities White Paper was binned, a ministerial cabinet committee on public health was closed down last year, and the promised cross-departmental mental health strategy has been subsumed into the department-led major conditions strategy. Now, I believe that just as government departments and large corporations accept the necessity to consider the climate impacts of their actions, so too policymakers need to consider and be held to account for the likely consequences of their action and inaction for health and for health inequalities. And just as economists have recognised the need to factor in the costs of failure to tackle climate change, so we must understand and acknowledge more fully the economic consequences of poor public health. So, we need to widen the way we approach health policy. But we also need to upend it. When most people think about the NHS, they conceptualise a hierarchy that starts in Whitehall and ends in the waiting room of a GP practice. The centre tells leaders of systems and trusts what to do. Then through command and commissioning, these leaders tell clinicians and other staff what to do. And then the public does its best to navigate what can be a complex and patchy architecture of available services. Now look, there's inevitably a hierarchy in the NHS. It's a publicly funded, politically overseen system. And there are some things which are genuinely done better in the centre. NHS England plays a vital leadership role, and it's to be commended not only for doing its best to resist ministerial micromanagement, but also for being willing to make difficult choices about its own scope and role. But still, the current model of accountability in the NHS is still overwhelmingly about what each level owes upwards to the layer above. Instead, we need to see accountability as something we owe outwards and downwards. As a number of leaders, including Cathy McLean, who's chair of Nottingham and Nottinghamshire ICS, have argued, we need to invert the pyramid. That means a centre that ultimately judges itself by whether it empowers and enables health and care leaders. It means leaders who in turn empower and enable their partners, clinicians, managerial colleagues, and ultimately it means a service that is oriented to empowering and enabling patients and communities to manage and improve their health and well-being. Now, this issue of accountability may seem secondary in the face of our pressing day-to-day challenges. But research demonstrates that decentralised organisations in which the leaders of cost centres have autonomy perform better than those that are highly centralised and tightly controlled. Equally, staff who feel they are trusted to make choices, to show initiative and to speak up about problems are more productive and contented. And the evidence is growing that patients who feel they are being seen, listened to and given agency will not only get better outcomes, but will feel better about those outcomes too. It should be obvious that many initiatives that are vital to the success and sustainability of the health service, from hospital at home to anticipatory care and from medicine adherence to the take-up of new diagnostics, rely on patients feeling trusted and engaged. Now, the long-standing argument for decentralised systems has now tilted significantly, something we at the Confed underlined back in 2021 when we commissioned Sir Chris Ham to write a report on the changing role of the centre. By establishing integrated care systems on a legal basis, the 2022 Health and Care Act introduced important and widely welcome changes in the way we work. Unfortunately, it's not clear that the NHS has adapted to that new reality. Crucially, integrated care systems, and particularly integrated care partnerships that set the overall strategy, are collaborative bodies looking at health and care in the round, promoting integration and mutual accountability with local elected authorities and other parts of the public, voluntary and private sectors. As it is for systems, so it is for place bodies, generally led by local government, And building on the excellent review by Dr. Claire Fuller, we're seeing the development of integrated neighbourhood teams. Innovation in the health service is often portrayed as something largely technocratic and top-down. But the most exciting glimpses of the future I've seen have been local and they've been human. In the face of public worries about access and the shortage of GPs, there's understandably much concern about the state of primary care. By the way, I see that in 1970, this lecture's inaugural year, the UK was second in the Eurovision Song Contest with a song called Knock Knock, Who's There? So clearly issues of primary access existed even then. But in recent months, I've seen fantastic practice led by inspirational GPs and primary care managers in Gloucestershire, in Peterborough, and in Sheffield. Standing out in this work is a commitment, on the one hand, to improve population health and reduce health inequalities, and on the other, to work with partners in the health service and beyond, and with community organisations. Through the work of social prescribers, health coaches and navigators, mental health peer counsellors, and many others, these primary care innovators are seeing neighbourhoods not just as the places where patients live, but as connected communities with assets to be drawn on and developed. The most inspiring primary leaders don't see themselves as the furthest reaches of a national bureaucracy, but as street-level entrepreneurs, knitting together networks, services, and bits of funding, focused always on working with others to improve the health and well-being of communities. Improving health outcomes relies on the NHS working in collaboration. Local government and other partners share our goals. They're enthusiastic about working more closely with us. But often, they wonder how much value there is in partnership with NHS bodies that have such limited discretion, who seem to be pulled from pillar to post by an ever-changing set of national priorities, and who have so little scope to question the underlying value for money of NHS interventions. Another challenge is obvious to all of us who work in and around health and care, and that's investment. Not just increasing the amount, but also reconsidering how and where we invest. The debate about the resourcing of the NHS is complicated and contested, but let me just draw out a few key points. The trend rate of growth in NHS spending over the last 75 years has been 3.6%. That's broadly in line with the growth that health economists say is necessary to respond to population ageing, rising expectations, and more expensive forms of treatment. Inflation-adjusted spending in the NHS has risen by about 10 times since its creation 75 years ago, but it's worth reflecting that the number of people over 75 has increased by 6 times, and the number of over 85s by around 8 times. And these numbers will continue to grow. But perhaps most tellingly, given that we tend to consume the highest proportion of health and care in our final year of life, is the fact that it's projected that the number of people reaching that final year of life will rise by 12% over the next 10 years and nearly a quarter by 2043. Cancer treatment exemplifies trends in the standards, the expectations and costs of care we're able to deliver. Although the UK lags behind many other countries in cancer outcomes, over 54% of adults diagnosed with cancer in England and Wales will now survive for 5 years or more. That is an increase from 29% in 1971. And of course, most of those kept alive will rely on close monitoring and frequent treatment. New developments in cancer treatment are exciting, but they can also be incredibly expensive. Nowhere is this truer than the development of immunotherapies. When, in April this year, NICE and NHS England approved the addition of 2 new indications for CAR-T therapies to the Cancer Drugs Fund, it represented an opportunity to provide those treatment to hundreds more patients every year. But the journey to this point has been long and expensive, and as a result, the cost of a single course of Yescarta treatment without the NHS significant discount is £300,000. A study from the US found that the median cost of developing a cancer drug was $650 million. But in recent years, the NHS has not kept up with demand, expectation, and potential. Analysis, again from the Health Foundation, suggests that if UK spending per person had matched the average across the EU 14 countries between 2010 and 2019, the austerity decade, UK spending per year would have been £40 billion higher at the end of that decade. And that means we've been forced to make hard choices about what parts of the system we prioritise. We went into COVID with 100,000 NHS vacancies. That figure is now over 120,000. Our profound challenges with workforce have been highlighted by industrial action, staff survey findings, and worrying retention rates. And some areas of spending have suffered particularly badly. The fondness of ministers for talking about prevention is cast in a dim light by the fact that the public health grant has been cut by over a quarter in real terms since 2015-16. And of course, those cuts have fallen disproportionately on the poorest areas. We're failing our children. Demand is rising for children and young people's mental health services, but only a third of those needing care can access it. And of course, social care is vital to the health system, not just, as commentators may sometimes make it seem, to help us get old people out of hospital beds, but because it plays its own important preventative role. Social care shows that devolving control of vital services only works alongside adequate investment. But between 2010 and 2022, local government spending power, that's the main source of adult social care funding, decreased by 29%. So the gap between us and our competitors is even greater when it comes to capital spending. The OECD finds that UK capital investment in health is around a third lower per head than in comparative EU countries. This is why the NHS capital investment backlog is now over £10 billion. And of course, the slow and inadequate funding of capital projects is a major impediment to the NHS taking advantage of new developments in technology and treatment. The truth is undeniable. In order to meet rising demands and expectations, to make the most of advances in medicine, we need better, more sustained, and more equitable funding for health and social care. But this reality can sometimes drive a narrative that sees the NHS, to mix my metaphors, as either a bottomless pit into which public spending is poured, or as a sheet anchor holding back economic dynamism and growth. And that's a narrative that can and should be challenged. First, and fortunately this is starting to gain traction, this argument, we need to acknowledge the economic value of health investment and conversely the economic consequences of a failure to invest. The NHS Confederation, my organisation, commissioned research which showed that for every pound invested in health on the NHS, £4 is returned to the wider economy. Recent research by the think tank IPPR found that experiencing a physical health condition was associated with a drop in annual earnings of between £1,700 and £1,800. Lost earnings have a significant impact on GDP. IPPR estimates that the long-term sickness associated loss of earnings cost the UK economy £43 billion in 2021, equivalent to about 2% of GDP. Secondly, health is the fastest growing global marketplace, with the WHO reporting that global healthcare spending reached $9 trillion in 2020. The NHS, despite our challenges, retains a strong reputation internationally, with health systems across the globe looking to the UK for partnership and collaboration. There's scope, opportunity to encompass innovations in everything from pharmaceuticals and medical devices to models of care, digital solutions, training, as well as opportunities for additional revenue to be invested into frontline care. Engaging in the global health marketplace opens up the NHS to new insights from our international partners. And then thirdly, to rebut this idea that health investment is money poured into a bottomless pit, biomedical, digital and service innovation gives us scope for major advances in productivity in future years. Now this could on its own be the subject of many speeches, but let me pick out some examples. Sometimes progress can mean the effective conquering of a disease, as we're on track to do with hepatitis C. Or it may be the development of new services and treatments that mean we can head off illness and massively reduce their impact. Using relatively cheap treatment, we've made great progress in relation to preventing cardiovascular disease, and mortality rates have fallen by around a half, although even that progress has now levelled off. Having just watched a close relative of mine achieve remission of type 2 diabetes and at the same time become fitter, happier and more self-confident, I, like many of you, have seen the opportunities offered if we can identify those at risk and give them the right advice and support to take control of their health. From wearables to hospital at home, digital health can help us keep people healthier, intervene earlier, and offer treatment which is more personalised and humane. And as we get better at collecting, analysing and sharing data, we can segment the population and make sure services are designed around people's risks, needs and preferences. Just about every health leader I speak to would like to be spending more time on innovation, improvement and transformation. But in a service that lurches from crisis to crisis, finding the time, money and commitment to innovate is hard. The investment case for preventative intervention requires evidence, but it's difficult to show that effect in these kinds of circumstances. It's like trying to use a spoon to bail out an overflowing bath while the taps are still on. The NHS is currently unable to take advantage of the innovative possibilities emerging almost every day. Now, the public remain deeply committed to the egalitarian principles of the NHS, but those principles are under pressure more than ever before. The decisions we make as a society over the coming period will determine whether technological and biomedical change enables continuous improvement in the offer we make to everyone through the NHS, or whether it will divide ever more widely the healthy haves from the unhealthy have-nots. So despite the complexity of its finer detail, investment is a problem we in health find it easy to talk about. But there's another aspect of the investment debate. While the overall funding of the NHS may be out of our control, we have more influence over where the money is spent. And it's in relation to this that we need to aim for an upstream, or as it's sometimes described, leftward shift of resources. This means investing proportionately more money into primary, public health, prevention, community-based services. This has been the stated intention of NHS policy for many years, yet as we all know, the reverse has happened. Since 2016, the number of full-time GPs has fallen, while the number of hospital medical staff, and particularly consultants, has risen substantially. I spoke earlier about the decline in funding for public health, the perilous state of social care. Part of the reason we've not only failed to achieve this leftward shift, this upstream shift of resources, but gone in the opposite direction, is the central control I discussed earlier. As Malcolm X once said, it's the hinge that squeaks that gets the grease. And in terms of public and media attention, it's elective backlogs, waits in accident and emergency, and corridor care that get the most attention. The Prime Minister has a health pledge, but it's not to improve health outcomes or bolster prevention, but to reduce elective waiting lists. Conversations with Whitehall officials confirm that anything that isn't immediately relevant to that target is considered pretty much irrelevant. Now, most health leaders, including those who run acute trusts themselves, recognise the need for the shift of resources if we're ever to get off the hamster wheel of trying to meet ever more demand for hospital-based care. System leaders, people who run ICSs, see actioning the shift as one of the most important measures of their medium-term success. The international evidence from community work in Brazil to HMOs in the United States show that such a shift can be achieved and make a difference. Yet we shouldn't underestimate how much collaboration, skill and commitment will be required to make this happen. If we're going to make the hard choices, then leaders in every part of the health and care system need to be convinced these choices will pay off. The upstream shift should be reasserted as an explicit long-term objective. But as Joe Rafferty, head of Merseycare and an innovator in the use of population data, argues, to get proof of concept, we need initiatives that demonstrate fast feedback loops, that if we move the investment, it has an impact quickly. And I've seen examples of these kinds of shifts in many different forms. In different parts of the country and in areas ranging from dermatology to mental health, I've seen primary and secondary colleagues working together to enable people to access diagnostic and treatment services outside hospital. Virtual care has been portrayed as a way of accelerating discharge, but it can also play a vital role in stopping people needing to go to hospital. In a part of South London, for example, the Community Trust has been able to persuade social care colleagues to change their eligibility criteria and support patients in virtual wards and their carers. The crucial factor was data that showed patients in virtual care were more likely to return to independence than those who got stuck in hospital. the point of the speech where I lose my way. A very different example is a digital hub in which service managers work together to reduce unnecessary ambulance conveyancing to A&E. In one example I saw from the south of England, nearly 2/3 of those Category 2 calls that were referred to the hub required no rapid onward referral. And there were 3 aspects of this digital hub that I found interesting, looking for examples of ways in which we can shift patterns of care. First, the importance of trust and reciprocity. Before the hub was established, the ambulance service had made limited use of the directory of service to avoid conveyancing. Too often their calls went unanswered. They'd been told that community facilities were full. So the game changer came when the digital hub team committed to expedite every call that was passed on, only returning to the ambulance service a tiny proportion of cases that actually needed to go to A&E. Another aspect was that by working together in the hub, managers from different parts of the system, the NHS, social care, voluntary sector, they saw each other's services in action, what was working and what wasn't. And this led to conversations about how to use resources better, reduce the tendency for different organisations to be defensive about their services. And thirdly, the hub was starting to generate and share data which could enable them to start to think about acting more proactively to meet demand earlier and to focus secondary prevention. The leftward shift, the upstream shift, needs to be seen not just as an aspiration, but as a way to tackle some of the most pressing operational issues we have now. So, for example, at the Confed, we're encouraging conversations now in systems and places about how we build resilience ahead of next winter. One aim in doing so is to encourage the Treasury and the Health Department to invest winter funds in ways that are more aligned to a long-term vision rather than just last-minute panic measures. And we need to explore other avenues to achieve that shift. At the Confed, we're working with partners to explore the scope for models of social investment in which upfront money generates a return through reducing demand. Ultimately, I think every integrated care system should aim to have a portfolio of social investment projects. But let me turn now to one final initiative that I think is vital. The 75th birthday of the NHS is an opportunity for a reset and for a new conversation with the public. A public that is, polls tell us, less happy with access to NHS services than at any time in the service's history, but that still values highly the care it does receive and holds firm to the service's founding principles. Could the shifts I've described in this speech provide the basis for a renewed national social contract on health? This is an idea that lay behind the development of the NHS Constitution. It was also central to the fully engaged scenario advocated by Derek Wanless in his 2002 report. We can also learn at the national level from local initiatives like the Wigan Deal for Health and Wellness. It's often the case, I found, in policy and politics that good ideas have to wait until the time is right to become fully mainstream. Today, as we look out on an NHS in many ways more challenged than ever before, yet reaching its 75th birthday still with wide and deep public support for its founding principles, today may be the time to appreciate and act on the established insight that the quality and depth of the NHS's relationship with patients and the public has become mission critical. What would the core tenets of a new social contract be? On the one hand, as I've described, from government, a commitment to sufficient and sustained funding for the health and care system, along with a national mission for health improvement, mobilising all parts of government and civil society. On the other hand, through inverting the power pyramid, moving up investment upstream, can we change the model of healthcare from one in which we incentivise activity levels, measured by treatments delivered to patients as largely passive consumers, to one in which health and care outcomes are co-created by the service and the people we serve? See, our health choices have implications not just for us, but for everyone else. Compelling people to monitor their health, to follow health advice, adhere to treatment programs would be counterproductive and unworkable. But social norms and expectations make a difference. Look at drink driving, smoking, attitudes to sexuality, all areas where the law has played a role, but the main driver has been a shift in the public sense of what is right, right for ourselves and right for each other. The idea that the public's attitudes, expectations and behaviours are vital to the sustainability and success of the health service is obvious. Yet it's not something our leaders are often willing to articulate, much less act upon. I spoke to a senior politician about this just recently, and his answer was telling. He said, "How can I lecture the public when they can't get a GP appointment or find a dentist for their children?" Another objection to seeking to raise our expectations of how people approach their health and use health services is that it smacks of authoritarianism, a denial of our personal space and freedom. Yet we know that health is the single biggest factor determining people's sense of well-being. Poor health is not just about the physical symptoms, it robs us of control and possibility. When we discuss public responsibility in the NHS, the focus tends to move to specific, often punitive measures like charging for missed appointments or denying treatment to people who smoke or overeat. But the conversation we need should be about shared responsibility, not blame, about empowerment, not punishment. If our future relies on people feeling agency and responsibility, how do we enable people to make the choices that are right for them and good for the rest of us? At the policy level, this might involve the greater use of deliberative processes like citizens' juries and community planning to shape and legitimise choices about service configuration and spending priorities. As I said earlier, the NHS is good at evaluating the value for money of individual interventions, but much less good at understanding, let alone acting, on the overall relationship between investment and health outcomes. So a better public conversation about priorities and trade-offs is one in which can enable the public to see their role in an approach that combines public resources, state action and collective action. Let's just take one current example. If national government were to hold a citizens' jury on smoking policy, I'm absolutely confident it would lead to the conclusion that we should immediately adopt the advice of the recent Khan Review, follow New Zealand in annually raising the legal age to smoke, while at the same time significantly increasing investment in smoking cessation services. At the service level, this is about engaging patient groups as partners with the right to shape services and the responsibility to help those services improve. Take, for one example, the growing evidence of the power of mental health peer counselling. Not only does support from someone who's had themselves experienced mental illness help patients, it seems to be therapeutic for the counsellors themselves. My relative, the one I described earlier, is very grateful for the advice and support that enabled her to ward off diabetes. I suspect she would welcome being asked to advocate for and support others to embark on her journey of recovery. Experts by experience can provide valuable insights into service design. I'm proud that the Deputy Chair of the Confed's Mental Health Network is such an expert, and we have a trustee with a long-term condition as a patient champion on our board. The NHS draws on the work of hundreds of thousands of volunteers, many of whom were inspired by their own experience or those of their loved ones. And at the individual level, we need to offer and expect more. This principle is, for example, vital in exploiting the potential of health data. The recent commitment in the Primary Recovery Plan to accelerate and widen the use of the NHS app can help people see the benefits of digital engagement. The Our Future Health UK project is showing both the insights that can be generated by accessing patient data, but also the willingness of the public to share when they can see the potential benefits. A very different example of how we should aim for greater shared responsibility and a more ambitious relationship between clinicians and patients lies in the incredibly well-known evidence that if patients have longer initial consultations with their GP and where there is continuity of care, they're more likely to feel positive and active about their health and to follow advice on behaviour and treatment compliance. Look also at the emerging evidence from experiments in reaching out to members of disadvantaged communities or isolated individuals, such as one fascinating trial currently undertaken in Westminster, where a service as seemingly simple as community health workers visiting at-risk residents has resulted in these residents being 47% more likely to receive immunisation and 82% more likely to have taken up cancer screening compared to other areas. And again, the benefit is not only helping people get the right care, but encouraging them to look after themselves and use services more effectively. Already, it feels a long time since everyone was talking about learning the lessons of COVID. We were so determined, weren't we, that our response to the terrible sacrifice and suffering of the pandemic would be to make the world a better place. But time, events, Downing Street parties, lockdown, culture wars, well, they seem to have sapped our will. But it's not too late. Shouldn't we mark the passing of the virus as a global emergency by recommitting to that learning? We learnt that people respond with responsibility and generosity to the need to protect themselves and each other. We learnt that people would happily undertake regular diagnostic tests and then act on the results, even if it meant making sacrifices. We learnt that without concerted action, major illnesses impact communities unequally and in ways that exacerbate disadvantage and exclusion. But we also learnt that if we listen, if we work in different ways, if we form different partnerships, for example, with voluntary sector and faith groups, we can reach out to those people and neighbourhoods who have reason to lack agency or trust. And also, importantly, we learnt during COVID that with a clear and shared sense of purpose and the right infrastructure, local leaders and organisations could be left to find their own solutions and to act on them with speed and creativity. A new social contract for health can not only memorialise the collective spirit of our COVID response, it can exemplify that spirit, applying it not just to an emergency, but to a vision of an NHS renewed. In the coming period, bioscience and technology are going to give individuals ever more opportunity to take control of their health. Clinging on to paternalism is neither honest nor progressive. Unless we address the social conditions that make people sick and rob them of control, unless we build deeper trust and an enduring sense of shared responsibility between the health service and the people and communities it serves, then these opportunities will widen even further the health inequalities from which we already suffer. The simple truth is the NHS needs the support of people just as much as the people need the support of the NHS. Despite all the challenges we face, I believe the best days of the NHS still lie ahead. A universal, equitable service, beloved by the public, provides the best foundation for the new social contract I have started to outline. Sufficiently funded, properly supported, devolved, preventative, empowering, our health service can be ready to grasp the opportunities offered by science and technology for a transformation in our health outcomes. I think it's a future that's worth fighting for. Thank you.
Well, thank you so much, Matthew. That was an inspirational talk and brilliantly on time, absolutely on time. So it's given us some time for questions. And I'm going to do my sort of Fiona Bruce bit here, probably not nearly as well as she would. So I'm going to ask the audience for some questions. Maybe I'll start off with one of my own, which is, I think not everybody in this room will really understand exactly what the NHS Confederation is and does. Could you just explain that for us?
So we are fundamentally a membership organisation, so we represent all parts of the health service in England and Wales and Northern Ireland. So that's the heart of what we do, but we also contain within those NHS Employers, which is the organisation that negotiates on behalf of NHS trusts, NHS employers. And we undertake a range of other bits of work. We do policy work, advocacy work, and increasingly actually we're focusing more and more on working with our members to drive improvement in the health service. I think the big idea about the Confed is basically this, that as I said in my speech, and I didn't elaborate on this, but if you look at the evidence of what makes systems and organisations succeed, it suggests that what you need is the right combination of kind of top-down drivers for improvement, strategy, hierarchy, accountability, lateral drivers that are to do with culture, professionalism, peer-to-peer support, and then bottom-up drivers that are to do with being responsive to the public, customers, patients, or whatever. The problem with the NHS is it is just far too much driven by top-down rather than those kind of lateral and bottom-up pressures. So I guess what we're trying to do at the Confed, and I think in doing this we're going with the kind of grain of NHSE policy, is for the Confederation to become a stronger driver of that kind of lateral change, because we are a membership organisation working with our members so that improvement is driven by members learning from each other a bit more rather than always responding to the kind of commands that come down from top, at the same time as also being more responsive to communities and the public.
And your relationship with the Department of Health and NHS England, for example, how does that fit together?
So most of the time it's to work collaboratively. So, for example, the recent Hewitt review, we effectively acted as a kind of twin secretariat with the department in relation to that. We're working closely on the new review for major conditions. But sometimes it involves challenge. Sometimes it involves us speaking up. I talked in my paper about a report we commissioned from Sir Chris Ham on the need for the centre to adapt to this new world of integrated care systems, and I wasn't quite doing that. So I think we are 3/4 of the time ally and 1/4 of the time irritant. And that's the way it should stay.
Right. Sounds like my marriage, actually. Yeah. And my wife's in the front row here, so I'm in trouble for that remark.
She's saying nothing.
Let's. I can see some hands going up all over the place. Well, we've got Angela on that side, and we've got Georgia somewhere with the other mic, and we've got to use the mic. So, Angela, do you want to bring? Let's have the gentleman with the dark tie there in the front. It's a bit random whom I'm going to choose, but I do want as many questions as possible. Questions rather than comments, ideally, because we have had in the past rather long comments. So, a question for our speaker.
Thank you, Matthew, for a really, really interesting and engaging presentation. You spoke in the second part of your talk about the need for a renewed national social, I'm struggling to read my own writing here, contract or compact?
Contract or compact.
On that very stage a few weeks ago, at another public lecture, a speaker was asked by a member of the audience a question which I'm sure you're often asked or often hear, which is, which other healthcare system somewhere in the world is the right system and which one should we copy? That speaker very sensibly said, well, we are the UK. We have our own culture. You can't just transplant systems from one setting to another. Now, you've mentioned...
Rather quick question. Yeah,
you've mentioned the need, for
yep.
To change social norms in order to address that social compact. Now, which social norm do you think would be easiest to change in this country? And which social norm do you think is not even worth trying because it's so deeply embedded in our culture?
Well, I talked about smoking. So, you know, I think smoking is just a kind of example of something where the public are ahead of politicians. And there was a review undertaken by Javed Khan, and he recommended that we do, as I say, what New Zealand has done. So in New Zealand now, the year at which buying cigarettes is legal goes up by year every year. So it's 19 this year, it'll be 20 next year, 21. So over the next few decades, they'll get to the point at which smoking has stopped. And I don't think it's going to wait until it's banned for everyone under 75. It'll just gradually die out. And also much greater investment in smoking cessation services. So it's not, you know, if you're going to take away that, you've got to support people. So, you know, smoking it's been a transformation. I talked about the way that it drove sickness in the post-war era and that it's declined. So that's one area where I think we're kind of on the verge. The government is, I think, ostensibly committed to ending smoking by 2030, but it's not going to do that unless it acts. And as I say, the public is kind of... It's funny for me, this issue, because I actually worked in Number 10 when the smoking ban was introduced. And I remember it was quite controversial, but I wonder how many of us would like to go back to sitting in restaurants and pubs and having to, you know, chuck our clothes in the washing machine when we got home because they smelled the smoke. So that, I think, is an example where we could move quickly. I think that drugs policy, if you said to me, where's a really intractable area, which is difficult to resolve, I think drugs would be much more difficult because of the criminal justice kind of dimensions of that. But earlier in your question, you kind of said, well, can we learn from other places? And I think we can. I think you need to learn elements. You can't import the whole of another system. So, you know, we could learn a lot from what Finland did to transform its public health in the post-war era, where, you know, it had It did everything from changing its national dish. The national dish of Finland was full of animal fat, and it redesigned the national dish so that it was healthy. But it did all sorts of other, much more substantial things. But it had a huge impact on, I think, the Finnish are amongst the healthiest people in the world now. Or we could learn from some of the best health management organizations in America that are now funding the health system and hospitals on outcomes. They didn't do it overnight because it's a big shift, but they said, in 3 years' time, we won't be funding you on activity levels, which is how we fund stuff now, but we'll be funding you on outcomes. And that led those hospitals to have to work in very, very different kind of ways in terms of population health, for example. So I think there's bits of practice that we can learn from many different places, but you can't pick up a whole system and drop it down, partly because, as I said in my speech, what you do in the health service is so related to all the other things that are going on around the health service.
Question there. The gentleman behind the lady with the blonde hair, Mary, if you could, yes. I think it looks like Ted Gordon-Smith to me.
Thank you very much. Yes, a very interesting polemic. Fantastic. Is this thing working? Doesn't matter if it doesn't.
You.
Yes.
I first worked for the NHS in its 15th birthday, which is jolly nice. And your last concluding remarks would have done jolly well at that time for a valedictory to the NHS, or at least an encouragement to the NHS at that time. In relation to what you've been asked so far in the questions, and to some extent what you touched on in your discussion, how are you going to bring together, and who do you want to bring together, all these questions about how do we deliver healthcare in the future? I mean, at the moment, it's a bit like a coral reef. Every time somebody has an idea, something's stuck on the edge, and it gets bigger and bigger and more unwieldy. Why can't you do something like climate change and say in 2050 we're going to have this sort of, or 2045, let's not be too, this sort of healthcare. This is how we're going to deliver healthcare. And one final point, in the 15th birthday, of course, the fantastic thing about the NHS, which made it so popular, was it meant that people who were sick, in pain and worried, they and their families did not have to be concerned about how they were going to pay for it. And it is a big mistake to think that taking away that part of the NHS in order to stop people smoking or being fat or so on something is going to be a popular or indeed a useful thing. And Nara and Bevan faintly hoped that curing people of being sick would mean that you wouldn't have to have any doctors, but I don't think that's true.
Yeah, so there's a lot in that. Let me just pick out a couple of points. So first of all, I want to be clear, because I said it explicitly in the speech. When I talk about shared responsibility with the public in a different conversation, I'm not talking about withdrawing treatment from people because we don't like their lifestyle, or fining people for not coming to GP's appointments. I don't think that kind of punitive approach works. I don't think it's cost effective apart from anything else, but I think it undermines the principles of the health service. But I do think we can have, and I think that's why I wanted to use the example of COVID, I think you can have a different kind of conversation with people. And nobody wishes that pandemic back, but it was pretty remarkable what the vast majority of the public did at a point where we needed to do things in order to try to look after and protect our health. And we've let that kind of conversation die back. As I said, I think part of the reason for that is because politicians, in government at least, feel embarrassed about waiting lists and GP access. And so it feels like we can't have that kind of conversation. But I think we have to have it, because in a sense, I think there's a kind of burning platform. And in so many areas, the things that we need to do are much better done if patients and the public feel themselves to be partners. And I tried to give a couple of examples of that in my talk. And so I'll say again, it's really interesting to me. We've disinvested in primary care. We have fewer GPs, but yet long-standing research that shows that if your first meeting with the GP lasts half an hour, it has a huge impact on how likely you are to be sick, how likely you are to look after your health, than if it's a 10-minute consultation where you don't get a chance to talk or the GP doesn't get a chance to ask questions. So, the danger is that as the pressure piles on, we make it a thinner offer, when actually what we need to be doing is engaging with people, engaging with communities. Again, another lesson that we've drawn from COVID. But let me take, the cost that is associated with people not complying with their medicines, for example, and we should be thinking deeply about that. What is it that we need to do so people are more likely to comply with the treatments that they are provided. And the point I make here is the thing we learnt in COVID and that we keep learning is that for certain communities, you do have to reach out. You do have to knock on doors. You have to engage community and faith groups. There are low levels of trust. You need to overcome that, as we had to do in COVID. And then as to your kind of main point, I guess what I've learned in policy and politics over 40 years in this game is that sometimes it's only when you're making an argument for the 25th time that it finally breaks through, that you kind of reach that tipping point. And given where the NHS is now, given the fact we've got an election coming, maybe this is the point to kind of say that all of the things that I've said in my speech, most of which are absolutely blindingly obvious, that there comes a point where people say, no, that is right. That is how we're going to have to do things. Because if we don't, we are just going to be caught in this kind of perpetual cycle of crisis management.
So it's a bit random, these, and I'm afraid I can't see the people at the back very well. So if I favour people at the front, that's going to be a little unfair, but I just can't see them at the back. The gentleman there with the spectacles, just grab the microphone. If you tell us who you are, that's helpful as well.
Yeah, sure. My name's Richard Daniels. I'm a paediatrician from London.
Hi.
Thank you.
Oh, that's better, yeah. Thanks.
As everyone said. My question is, I suppose, more oriented towards your time working in Number 10 and sort of the political aspect. So essentially, what you've said makes lots of sense. Just how do you actually enact it when you can't necessarily campaign to be elected on a complex reorganisation of the NHS? Like short, snappy headlines, policies are the ones that cut through. And then you have a Secretary of State for Healthcare who is going to be ultimately accountable for any change, but not see any benefits for a long time, whilst also taking the flak for whatever goes on in the meantime. So why would they be incentivised to push it through from a political perspective? I know the evidence and I understand the policy, but how would you actually deliver that if you'd been in Number 10?
So it's a brilliant and depressing question, and absolutely accurate. Why is the Prime Minister's health pledge not to improve health outcomes but to reduce waiting lists? Because it's the thing that we see. It's the thing that newspapers tend to, I'm not criticising the media, but that's what they'll tend to report. So I'm not unrealistic about this. When the next election is fought, the major parties will have what you call in politics a retail offer. They're bound to. And there are certain national targets that are appropriate. But what you've got to try to do is to associate that with some deeper thinking about change. And I do think that there is a greater public understanding now that, this, partly because, whoever wins the next election, we're not going back to the years of New Labour and that kind of increase in funding. So there is no, there's no Tony Blair on a kind of, or Gordon Brown on a shining, a white charger coming in to kind of bail us all out. It's going to be tough. And so I think conversations I have with politicians are around recognising the need for national accountability and the fact that there will be this kind of retail offer, but encouraging them also to open up a different kind of conversation, to trust the public actually a bit with a different kind of conversation. So, that's why I was delighted to do this talk tonight, because even though there's nothing I said in my speech that I don't feel I've said 100 times before, you have to keep pushing. And now, at a time when we're under this kind of pressure, maybe this is the point at which the public is willing to listen to that. And as I said in my speech, sometimes we can be resigned about public opinion, but actually public opinion can shift really quite quickly, as it has on climate change or sexuality or smoking. If you get to that point, people go, no, that's right, it does have to change. So we have to keep banging on with it. But you're right. Of course, national politicians will have national targets and be accountable for those, but that doesn't have to be the whole story, I don't think. It's also interesting, I think, that most of what I said in my speech is kind of national policy. It's just that we're not doing the things that are necessary to actually make national policy. Most of my principles could be culled from the NHS long-term plan, but it's difficult to do.
Let's have a question from the back. Is that... Yeah, the gentleman in the blue shirt there. Thanks, yeah.
Quick question. Young people, they've been quite good at recycling and looking after climate control, etc. What do you envisage should be a policies change at a school level to influence healthcare going forwards?
Yeah, I think that's really interesting. And I think that, part of the reason why I argue for this kind of inverting the pyramid and devolving more powers, because if the health service is going to work with local partners, it's got to be able to give and take. And unfortunately, the conversations I have with health leaders locally is that they find it hard to have that kind of collaboration with, for example, head teachers or local authorities, because they've got so little room for manoeuvre. So it's hard to do a deal with somebody who's got so little latitude. But no, I absolutely think that health has got to be an important part of what we teach in schools, and there is good practice. The development of mental health provision in schools, which is something that we and others argued for, which really didn't exist many years ago. And I think now about 40% of secondary schools have got mental health experts within the school, and it's making a difference. It's really, really important that we give young people the kind of techniques to understand issues around mental health and the capacity to kind of manage those. So yeah, we could be doing a lot more. We've seen various campaigns, haven't we, about food in schools and exercise in schools. I think that, it's a different debate. I think one of the other big debates that's going to be happening over the period between now and the next election is what do we do in schools, and how do we shift the focus not just from being on standards, but also to being on the wider well-being of children. And I think health is a really important part of that. Yeah, absolutely.
Integrated care systems, are they the solution, do you think?
Well, I think someone talked about reorganising. I don't want to reorganise the health service, and be absolutely clear about that. I think that integrated care systems are fine. I think the problem is that we're not creating the right context for them to thrive. But I absolutely don't think we need to reorganise the health service. I mean, let's remember the last 2 times we elected a different party into power, 1997 and 2010, both times we undertook a major, completely pointless reorganisation of the health service that cost billions of pounds and smashed goodwill. So Frank Dobson dismantled the internal market only for it to be recreated by Alan Milburn, and Andrew Lansley reforms, well enough said. So I think the one lesson we can learn from the past, if there is going to be a change of government next year, is don't reorganise. Unfortunately, Wes Streeting so far seems publicly to be saying that we don't need to reorganise that. There's lots of things we need to do, but we don't need to change the structures.
We've had Wes Streeting here, and we had Camilla Cavendish actually last week making the point about the political football and the pointless changes. We but have a question from that side of the audience there. The lady with the scarf at the top there. Nice quick question because we're running short of time.
Yeah. Also a quick question about, in your topic you said reset. Reset what? Do we need to reset the health policies or the bureaucracy? If you can explain a little much better.
Reset
the health policies or reset the bureaucracy?
So both. I guess what I'm trying to argue is that at the heart of what I'm trying to argue is that we need to understand health as the outcome of a relationship that we have with the public and with patients, rather than as something we deliver to people as a kind of set of treatments in which they're kind of passive. That the future of the health service, the sustainability of it, depends upon the public being more active partners in how we have a sustainable health service. But to get to that, it seems to be we need to change the way in which the health service works. So that's, in a sense, what I'm trying to argue in the speech, is that we need to invert the pyramid, we need to move money upstream, we need to work in different ways, we need to have proper investment. If we have that, that's the basis, it seems to me, to be saying to the public, well, we can do things better on our side in the health service, but we need you to step up as well as partners in creating a system that can really thrive. And if we don't, as I said in my speech, what really worries me is with the ever-growing scope that exists for individuals to empower themselves. You go on the underground and there are adverts all over the place now for ways in which you can undertake diagnostic tests, have a DNA test of your cancer sample, whatever it might be. There's more and more scope now for people to just say, well, I'll go out on my own. And yet the public really is committed to the NHS's principles. So we need to work in a different way if we're not going to see those inequalities divide. And as Richard Titmuss famously said, a service for poor people quickly becomes a poor service. So we need to hold on to the universalism of the health service.
AI is another thing we could talk about. But the good question actually in relation to that one, what would be the challenges in shifting the NHS budgets upstream into primary care? What are your thoughts on how do we reduce waiting lists whilst we do that? Because waiting lists are such a big political priority, especially with Rishi.
So that's why, my speech hangs together perfectly. In the sense that you can't achieve that shift unless you have a proper sustainable funding. We're not going to return to the kind of the years of Labour's the money that Labour put into the health service in the early noughties. But we do have to have sustainable funding, because what you can't do is say to acute colleagues, well, we're taking money from your hospital now, because they're under immense pressure. So you've got to have enough money so that you can increase the resources proportionately in prevention and public health and upstream, but you've got to sustain what you're doing in hospitals. And that's exactly where we are right now. So I talk to people in integrated care systems every day. They want to do more work in prevention. They want to do more work in primary. But the targets and the pressure are all on, elective care. They're all on A&E waiting times. And so that's where the energy goes. And that's why, I'm making the speech in a sense, is that the danger is, unless we try to address a different long-term vision, we will just spend all our time at the kind of end of the process, at the hospital end of the process, rather than moving upstream. And, I only said parts of the speech. There's all sorts of ways in which we could, if we did it in the right way, we could deliver better care and have fewer people ending up arriving in A&E departments because there's nowhere else to go, or they feel there's nowhere else to go.
Good point. The question there, the person in the blue dress, I don't actually know who that person is, but tell us who you are.
Hello, Nicola Stingerlin, RSM section member.
Thank you.
The role of the commercial sector, what is it? Without that, it doesn't work. What role should they play? What do you think? Thank you.
Yeah, I think in all sorts of ways, and I did actually, it was only one word in the speech, but I did say that one of the things about local partnerships is working with the private sector as well. I hesitate before mentioning the CBI because of what's happened to them, but before the troubles that they've walked into, the CBI is doing some fantastic work around health and employment, working with many of the country's leading employers around thinking around what they could do to support the health of their staff and support health more broadly. So I think the private sector's got an important role. I talked about life science industry, pharmaceutical industry. I worry, and there are warnings every day, that our lead in that area, our strength in that area might be eroded. I think that's got to be part of a kind of mission for health and a kind of renewed industrial strategy. So yeah, absolutely. And actually we in the Confed work a lot with private sector companies, pharmaceutical companies, medical device manufacturers or whatever. And what's interesting to me is, and this is genuine, they're not working with us because they want to flog drugs. They're working with us because they're interested in finding different pathways. They're actually often share the frustration that we have about the way in which they can see how a pathway could be redesigned in order to make prevention work better, but it's not happening. So yeah, as partners, as profit generators, as exporters, and as good employers, yeah, absolutely, really important that the private sector feels part of this.
I think it's 20 to 8, and we always finish with military precision. I'm sorry that we haven't got time for any more questions. A couple of announcements before I give the medal to our renowned speaker. So on the 24th of May, which is next week, John Appleby is going to be talking about healthcare and healthcare provision. On the 14th of June, we have Melanie Reid, who you might read on her weekly column in the Times. You might remember that she tragically fell off her horse and is tetraplegic, but still writes an amazing column every week for the Times. And then on the 20th of June, we'll be discussing, and I think it would be great if you could come along and join us, Matthew. We have an evening meeting, Operation NHS, Envisaging a Brighter Future, and that's a panel discussion. We're just inviting a number of very prominent health care people to that, so do come along for that meeting if you can. So a final thanks to our speaker, Edwin Stevens would be very happy to see this medal being handed over because he's supported this. That's your uncle, isn't it, Howard? That's your medal as a reward for this excellent talk. So thanks to the audience, thanks to the speaker, thanks to the Stevens family in the front row here. And there are drinks next door, so we can continue this conversation about the future of the NHS on its 75th birthday. Good evening, everybody.